So my name is Dr. Sarangi. I'm a geriatric psychiatrist based out of South Providence Clinic. So today I'll be talking about the psychiatric manifestations of Parkinson's disease. This is a very extensive topic, and I'll try to do justice to it in 30 minutes. So the goals for today for me would be to discuss some of the major psychiatric symptoms which come along with Parkinson's disease and how to manage them, and talk about some of the medication and non-medication options we have available for managing these symptoms. So let's jump right into it. So the first and the most common thing that I see in my practice is depression that comes along with Parkinson's disease. And it is the most common psychiatric disorder that comes along with PD. About 40 to 50% of patients actually suffer some, if not all, symptoms of depression. Mostly mild to moderate in nature. However, 20% of patients do have severe symptoms of depression, which significantly limit their overall functioning. Some of the risk factors that predispose patients to having Parkinson's disease depression include female sex, a younger age of onset, prominence of more right-sided signs, prominence of gait difficulties, and slowed movements, which overall limit functioning and day-to-day activities. Depression is sometimes also something that comes before the motor symptoms of Parkinson's disease. So if a patient is reporting depressive symptoms, it can be a significant clue that they may go on to develop PD in the future. Depression is also considered a risk factor for the development of Parkinson's disease dementia. So it is very critical that we identify this illness early and treat this as aggressively as possible. It can be quite difficult to diagnose depression because a lot of the symptoms that come along with Parkinson's disease can mimic, having depression as well. So what I really try to do in my practice is focus more on the psychological symptoms of depression rather than the physical symptoms. The physical symptoms can also come along with PD. So I think the best approach to go along is to really focus on the psychological symptoms. So I like to ask about loss of interest. I like to ask about sleep disturbances, any paranoid ruminations, suicidal thoughts, rather than focusing on psychomotor retardation or focusing on their affect and things like that, because that can also happen with this Parkinson's disease in general. So obviously, treating depression, it's a multifaceted approach, right? So we can't just focus on medications. It has to be a combination approach with psychotherapy as well as medications. That being said, some of the medications that we like to use in practice include the selective serotonin reuptake inhibitors, and you may have heard about some of these. The most common ones that we use in practice include sertraline, also known as Zoloft, and escitalopram, which is Lexapro. We do have to be careful with using these medications in patients with PD because a lot of the medications that our colleagues in neurology like to use can have some interactions with these medications. The most severe interaction can lead to something known as serotonin syndrome, which can be life-threatening. It can present as confusion, rigidity, restlessness, autonomic dysfunction. So there are some risks associated with these medications, and we work very closely with our colleagues in neurology in using these medications cautiously. Tricyclic antidepressants are an older class of medications that were quite common a few decades ago, and they're still utilized, just less frequently, because of their anticholinergic, sedative properties, which may be detrimental, especially in older folks. So these medications can lead to dry mouth, urinary retention, constipation, and have some cardiac side effects. So they are not really first line as much anymore. So as I mentioned before, treatment of depression is not just, medications, but also psychotherapy. And one of the most common type of psychotherapy we employ in practice is known as cognitive behavioral therapy. Outside of psychotherapy, if a severely depressed patient with PD fails to respond to any medications, we do have other non-medication options, including electroconvulsive therapy, And this is something that is very underutilized, I believe. And it's a very effective procedure. It's much different from how it used to be a couple decades ago. Um, but it's very underutilized and it's very effective. ECT has also been shown to improve mobility in patients with Parkinson's disease outside of treating depression. So let's shift gears a bit and then talk about mania and hypomania. Medications that we use in Parkinson's for the motor symptoms, so levodopa and other medications that work on dopamine, they may occasionally lead to mood changes associated with a sense of well-being. And this can range from depression, anxiety, euphoria, and mania. The rate of mania, hypomania is close to about 2 to 10% of patients. And patients who have a history of bipolar disorder, they are obviously at a much higher risk of developing these kind of symptoms. And usually these symptoms begin after the initiation of dopamine agonists and levodopa. It's really hard to say at what time of the illness or how long after starting these medications these symptoms may develop, but it's just definitely something that we need to monitor. In a few patients, occasional manifestation of hypomanic symptoms occur during times of peak dosing of levodopa. And also antidepressants along with other anti-Parkinsonian therapy may also contribute. So patients who do end up developing hypomania or mania kind of symptoms, they may display altered sexual behaviors such as increased libido. They may be hypersexual. There may be sexual deviations and various paraphilias which may occur. And this is quite distressing for caregivers. They may also exhibit sleep disturbances such as vivid dreams and nightmares with multiple awakenings in the middle of the night, disrupting everyone in the family. These can be managed by more frequent and lower dosing to avoid certain dosage peaks of levodopa. So I work closely with my neurology colleagues. I often reach out to them and ask them if something can be done about the dosing of the medications. If this is not always possible, we do have to introduce other psychiatric medications as mood stabilizers to help manage these. All right, so shifting gears again, we're talking about anxiety and panic. So anxiety and panic type of symptoms are also quite frequent in my practice. The prevalence is about 40%. It's much higher in the younger population. And it is often comorbid with depression. So I like to view depression and anxiety as first cousins. So if someone has depression, it's a very high likelihood that they will also have anxiety or symptoms of anxiety and vice versa. So generalized anxiety disorder, social phobias, panic disorders, it's all pretty common and they're all on the same spectrum. Having Parkinson's disease does come with a lot of functional limitations. So there may be speech deficits, there may be motor deficits, there may be gait issues. So patients are quite conscious about their limitations, especially in a public setting. And this can lead to significant symptoms of anxiety. So in some patients, panic attacks, they occur with the onset of what we call freezing or off episodes. So what happens is during fluctuations of the levels of levodopa, patients can exhibit severe symptoms of anxiety and panic attacks. So anxiety can be relieved by effective anti-Parkinsonian drug therapy. However, we also may need to use antidepressants. So a lot of the medication classes, a lot of the names in psychiatry for medications that we use are misnomers. So even though it says antidepressant, they are also effective for anxiety. We do know that anxiety and overall stress can worsen the resting tremor and other associated tremors that come with Parkinson's disease. So it is very critical that we manage any anxiety that comes with the illness. So, obviously there's a wide range of medications that's available out there. Some of the more common ones that we use in practice are buspirone and mirtazapine. So buspirone is an anxiolytic. It works better in the older population, and it's a medication that is usually dosed 2 to 3 times a day, and it's quite effective for anxiety. It does help with sleep, some, along with mirtazapine. Mirtazapine is a depression anxiety medicine as well that has been out there for quite a long time. It's effective for sleep, initiation, appetite, because we know a lot of patients with Parkinson's disease also have appetite issues. So a recent study did suggest that using mirtazapine does increase mortality in agitation. That does sound pretty scary. However, we hardly use mirtazapine for this purpose. Mirtazapine is most likely in most settings used actually for sleep and appetite initiation. So this is a useful table that, just kind of like to display with the various medications and drug classes. So the most common ones we use, as I mentioned previously, are SSRIs. And some of the medications are listed on there with the dosing. The main thing with using medications such as these is that we really want to start at really small doses, low doses, see how the patient is tolerating these medications, and then, go really slowly, titration as needed. Okay, so shifting gears a bit further, we'll talk about some of the other behavioral issues that come with Parkinson's disease. So compulsive behaviors, impulse control disorders, these are more common in patients with, again, who are using dopamine agonists than in patients who are not being treated with these medications. And it can affect up to 14% of patients on drug therapy. And this can manifest as pathological gambling, hypersexuality, compulsive buying, binge eating. So I've had patients who, have woken up in the middle of the night, adding stuff to their Amazon cart, things that they would not normally do, right? And it's quite distressing for caregivers, as you can imagine. So all dopaminergic anti-Parkinsonian treatments, as well as deep brain stimulation, have been associated with these behaviors. So some of the questions that I like to ask patients when I do see them or caregivers is this something that's new? Is this something that is really a deviation from their baseline personality? And that's what you really need to focus on. Without going into too much detail about the pathophysiology, basically it happens in the mesolimbic system of the brain where there's excess dopaminergic stimulation. So patients with a younger age at Parkinson's disease onset, patients who have a history of, more thrill-seeking kind of behaviors in their childhood, a personal or family history of alcohol use disorder or other substance use disorders, they generally tend to have a greater risk of developing these compulsive behaviors. So apathy. So apathy is a frequent symptom in Parkinson's disease. About 25% of patients go through this. It looks very similar to depression. It can be very hard to distinguish. However, patients who are not depressed can also have apathy, and it can be a manifestation of the illness itself. It may or may not be found in patients with a mood disorder. So what apathy basically is, it's a general lack of motivation, lack of initiation. The patient just doesn't want to do anything and has a difficult time waking up in the morning. There's no interest in starting anything new or completing any project. And there's an overall lack of concern for one's health. It is associated with cognitive dysfunction. It has been associated with dysfunction in the forebrain. And apathy is really on a spectrum. So patient usually starts with, having lack of general motivation, and then this goes on to apathy. And then the most severe form of this presentation is known as abulia, where the patient is just lying in bed. There's no drive to even get up out of bed. And a lot of these behaviors are, actually focused on the forebrain. That's where the pathology really lies. So in terms of, overall management for these conditions, we talked about depression. Depression might require specific treatment. We do want to avoid certain antidepressants which have marked anticholinergic properties. So some of the depression medicines, they are more likely to cause dry mouth or urinary retention or constipation. So you really have to work with your physician to kind of, picking which medication is really right for you. If depression is not an issue, then some of the medications that our colleagues use in neurology, levodopa, other dopamine receptor agonists, salicylic amphetamines, amantadine, these are some of the medications that, more often than not neurology uses, and these can be effective for managing apathy. patients who do require nocturnal sedation, who have a difficult time initiating sleep at night, they may need other antipsychotic medications or other medications that can promote sleep at night. So quetiapine is one of them. Clozapine is one of them. Clozapine is an antipsychotic. It's quite effective for hallucinations, for sleep, for anxiety. It does have some stringent requirements for blood work, which does limit its use. However, it's available. So bedtime hypnotics, medications such as benzodiazepines, zolpidem, which is known as Ambien, can be quite effective for initiating sleep. Centrally active cholinesterase inhibitors, so medications such as rivastigmine, which is FDA approved, was also found to have a benefit for apathy, anxiety, delusions, and hallucinations, especially in patients with dementia with Lewy bodies. For impulse control disorders, drug therapy really should be simplified. So we should try to get rid of, if possible, medications that are making the problem worse. And this has to be a decision in conjunction with the neurologist. So anticholinergic agents, medications such as amantadine, these can oftentimes be the culprit. Impulse control disorders in Parkinson's disease also responds well to deep brain stimulation of the substantia nigra. And then, of course, working with psychotherapy along with medications can be quite useful. All right, so talking about psychosis, psychosis can be quite distressing, not just for the patients, but also for caregivers. And a lot of patients who start to develop psychotic symptoms or are going through psychotic symptoms, unfortunately, at some stage of their illness, we may also have to consider nursing home placement, right? So I think it's very important to recognize psychosis early and then treat this aggressively as possible. So a lot of the medications, again, that we use for treating the motor symptoms of Parkinson's disease can unfortunately lead to psychotic symptoms. And the illness itself predisposes the patient to developing psychosis. Psychotic symptoms can occur in about 40% of patients with Parkinson's disease. The most common psychotic symptom that patients experience are hallucinations. So hallucinations is basically when you're sensing something when nothing is around there, right? So there's no stimulus, there's no sensory stimulus, but the patient is perceiving the presence of a stimulus, right? So hallucinations cause a significant proportion, occur in a significant proportion of those with Parkinson's disease, especially in our older population. And risk factors for developing hallucinations were higher the doses of your dopaminergic medications. Also, patients with a history of REM sleep behavior disorder at baseline are more predisposed to developing hallucinations. So usually most patients have isolated visual hallucinations. Maybe seeing things in the room or, seeing family members who are deceased, which can be, both comforting or distressing. But most patients actually encounter visual hallucinations more commonly. Most of these visual hallucinations, they occur at night. They are often associated with sleep disturbances. Visual hallucinations take the form of familiar humans, like I mentioned, or animals. Sometimes the patients have pretty good insight that these are false, and this is known as pseudo hallucinations. And it's quite common that the patient is actually not distressed. The hallucinations do not disturb the patients because the visual images are vivid, but oftentimes they're friendly, they're not frightening. And these are known as benign hallucinations and don't necessarily need any treatment with medications. They occur in clear consciousness with preservation of insight and cognition. Benign visual hallucinations are the most common psychotic symptoms in Parkinson's disease and are related to dopaminergic medications. So hallucinations may develop shortly, as I mentioned, after starting treatment with Parkinson's disease with medications. However, it's really hard to predict at what stage of the illness or treatment with medications it's going to happen. It is something that I think should be screened for at each and every visit with your doctor. Risk factors for the occurrence of hallucinations, several years of treatment, increasing age, higher dosages of medications, and multiple drug treatments. When we have done scans on patients with Parkinson's disease, we found the pathology to be really in the occipitotemporoparietal regions of the brain. sparing the occipital. But, it's not really necessary for everyone to go through, extensive imaging. I think what's more important is to identify the problem early and then treat it aggressively. So the other psychotic symptom that patients experience, delusions, paranoia. So delusions are basically fixed false beliefs, right? The prevalence of delusions ranges from 3 to 30% and is greater when higher doses of dopaminergic medications are used. Increasing age, presence of Parkinson's, dementia are some of the risk factors which are associated with development of delusions. They usually appear about 2 years after initiating treatment with levodopa. However, again, they can occur at any point of treatment or the illness course. They're usually paranoid in nature, so believing that people are out to poison you, or there's some kind of someone is tracking you, tapping your cell phone, things like that. However, there have been delusions of jealousy, right? So your partner is cheating on you, things like that. But most commonly, it's more paranoid in nature. Most of these patients usually do not have a full-blown, schizophrenia kind of like picture. This is rare, and they usually more commonly have isolated delusions. So again, going back to some of the medications that we use to treat these symptoms. So quetiapine, that's an atypical antipsychotic. Many of you may have heard of it. It's one of the most common antipsychotic medication that we utilize. It appears to be effective, however, only for milder, psychosis, such as hallucinations. But when patients do develop more distressing delusions, paranoia, sometimes the efficacy is lacking. The problem with using antipsychotic medications also is that they can cause a fall in blood pressure. They can lead to falls, right? So these medications are not benign. They do have side effects. So we always have to weigh the pros and cons of using these medications. Quetiapine can be utilized as a hypnotic in older patients with Parkinson's disease because it is quite sedating. So patients who do have difficulty with falling asleep at night or wake up in the middle of the night, it can be a useful medication. Clozapine is another medication. It's another antipsychotic medication that has been around for quite a long time. It is one of the most effective medications that we have available in psychiatry. The issue with using clozapine is that it has a very stringent blood monitoring requirement. So the patient has to go through weekly blood monitoring for the first 6 months. And this is not feasible for everyone. And the reason we need frequent blood monitoring is because it can lead to something called agranulocytosis, which is basically, that means, fall in your blood counts, and that can predispose you to infections, right? So not a benign medication. However, for patients who are able to go through the blood monitoring, it can be quite an effective medication. Other medications in that class include olanzapine, ziprasidone, risperidone, aripiprazole. So these medications are also effective. However, they're much more down lower on the list. Olanzapine can cause significant weight gain. It can worsen diabetes, increase cholesterol. So it's not, generally utilized as a first choice anymore. Risperidone can oftentimes make the tremors and the motor symptoms of Parkinson's worse. So also not utilized first line. Pimavanserin is a fairly newer antipsychotic medication that the FDA approved in 2016. And I've utilized this medication in a couple patients. The clinical benefit remains to be seen. The good thing about pimavanserin is that for patients who are going through, some of the blood pressure fluctuations that come with other antipsychotics or falls, pimavanserin, it doesn't do as much of that. So it can be, it's usually much better tolerated by patients. Problem with pimavanserin also is getting the insurance approval. It can be quite an expensive medication. So we do have to do some prior authorizations and, filling out paperwork. So outside of antipsychotic medications, what else can we use? So I mentioned briefly the anticholinesterase drugs. So medications such as rivastigmine, these can be effective also for patients with who are going through psychotic symptoms, especially if you want to avoid using antipsychotic medications Some studies have reported similar efficacy on psychosis compared to quetiapine. We also have the nausea medication that we are familiar with, ondansetron, also known as Zofran, and this has shown to have some benefit in reducing hallucinations, paranoia, and confusion in patients with Parkinson's disease. So if psychosis continues without, adequate benefit from using antipsychotics, we really have to work with neurology and ask, I asked them, hey, is there anything we can do to maybe cut down some of the, doses of the dopamine agonists? We really have to be cautious with that approach as well, because we don't want to worsen the motor symptoms of Parkinson's disease. So it's a very fine balance of doing that. But sometimes, what I like to tell patients is the psychological state of mind, sometimes that takes precedence. Not to say that the motor symptoms are not debilitating, but the psychological symptoms can be quite debilitating, and not just for the family, but for the caregiver, and it can predict nursing home placement, right? So at some point in time, we really have to cut down on some of the dopaminergic medications as well. If we can't stop the dopaminergic medications, we can, sometimes what we do is, some drug holidays. So maybe taking the medication on alternate days, or, skipping weekends or things like that, right? So to dispel psychotoxicity as much as possible. Intact mental function, as I mentioned, sometimes is much more important than an intact motor function. And resistant cases of psychosis, again, going back to ECT, it can be quite effective. So it's something that is underutilized, and we have that available at MU Health. So some of the more resistant cases are patients who are just not able to tolerate antipsychotic medications. They may find benefit from using electroconvulsive therapy.